So let's talk about heart physiology and how our heart sets a basic rhythm, which is what we call a sinus rhythm of about 75 beats per minute. The heart will depolarize, and which leads to an action potential, which leads to a contraction without any nervous system stimulation at all. So we don't actually have to have any nervous system stimulation causing our heart to contract, which we see in heart transplants. The heart can still function just fine with no nerves supplying it. However, your nervous system can adjust your heart rate, and it does this through the autonomic nervous system. Remember, autonomic means automatic. So this is the division of your nervous system that is supplying all of those involuntary organs. So like your heart rate and your breathing rate and digestive tract motility and pupil size and all of those things you don't think about. That's the autonomic nervous system. So a good example might be like when you are scared. Your autonomic nervous system can adjust your heart rate and elevate your heart rate. So before COVID, my husband had to go out of town. And whenever he's out of town, I'm just a little nervous, especially at night. And I lock all of the doors and check them 10 times. And I get my son to sleep and I'm laying in bed. And I just close my eyes and I hear our garage door opening. And I freak out. And my heart is going like, I'm like a hummingbird. It's going like 1,000 miles a minute. And I run to the garage door and I put my ear to it, trying to hear if I can hear somebody trying to break in. I have my phone in my hand and I'm like 911, and I'm ready to hit send. And then it dawns on me that I forgot to shut the garage door. And we have one of those things that will automatically shut the door at 10 o'clock if you've left it open. And I look and my phone says 10:01. So I got myself all scared for no reason. But, that's a good example of, when you are scared and your heart rate goes up because of that. That's the autonomic nervous system. So we don't need it. But it does help to control our heart rate depending on conditions, our mood, if we're sad, if we're happy, if we're scared, all of those things can adjust our heart rate. Now, a coordinated heartbeat is a function of a couple of things. You have to have gap junctions between the cells so that your cells can electrically couple. And there also has to be an intrinsic cardiac conduction system. This is basically a network of non-contractile cells that will send an impulse throughout the heart. Okay, so we say these are your autorhythmic cells. Again, they're non-contractile. Their job truly is to just send the action potential where it needs to go. They are initiating and distributing those impulses so that you get a nice coordinated contraction in your heart. So let's talk a little bit about this intrinsic cardiac conduction system. So it's going to start with the sinoatrial node. This is going to be the group of cells that are the fastest to depolarize. They're going to set the pace and the general rhythm for your heart, which is typically about 75 beats per minute. From there, an action potential will spread to the atrioventricular node, then through the atrioventricular bundle, then through the left and right bundle branches, and then through the Purkinje fibers. And I call them the Purkinje fibers. Your book will call them either Purkinje fibers or subendocardial conducting network. It uses both terms. So let's look at an image of this pathway. So again, I told you that your pacemaker, what is setting the pace, it's the fastest to depolarize, is right here. And this is called the sinoatrial node. Sometimes we call it the SA node. And again, notice right here, it's the pacemaker. So this one will depolarize. From there, the signal will move through the atrium, through the right atrium into the AV node. Now notice this is all only on the right side right now. There is nothing on the left side. The left atrium and the cells of the left atrium will still contract because they are coupled electrically with gap junctions, okay? Once the impulse gets to the AV node, there's going to be a pause. The impulse will just kind of sit there for like 0.1 seconds. It's a really short pause. But what it's doing is it's allowing the atria to go ahead and contract and squeeze that blood down into the ventricle. And then from there, the electrical signal will move from the AV node. It'll move down through this part called the AV bundle. And that's where it's starting into the septum, the interventricular septum. From there, it'll branch into the bundle branches, into a right and a left. And those bundle branches you can see move towards the apex of the heart, and then they branch profusely out to get to all of that myocardium. And those are called the Purkinje fibers. Okay, so that's the pathway. Now I want to walk you through each of those. We're going to start with the SA node. I mentioned this is the one that sets the pace. It is the first to depolarize, the fastest to depolarize. So this is why we call it the pacemaker. It's only found in the right atrium, like you could see in that image, and it generates a sinus rhythm of about 75 beats per minute. Now, someone who's really healthy can have a sinus rhythm if they go through, if they do a lot of cardiovascular activities, their sinus rhythm can be 60 beats per minute if they're incredibly healthy and have a strong cardiovascular system. The impulse is going to spread from the SA node across the atria to the AV node. And I mentioned that the AV node, the atrioventricular node, this one is named appropriately. It's between the atria and the ventricle. This one's going to delay the impulse for about 0.1 seconds. And that is just going to allow the atria to contract before the ventricles so that we can make sure we're moving blood the right direction inside the heart. From there, the impulse moves down the bundle. So it's starting to move through that interventricular septum. This is actually the only electrical connection between the atria and the ventricles. So I told you that the two atria are connected by gap junctions, but not the atria and ventricles. So having this atrioventricular bundle is really important because it's connecting the electrical signal from the atria down into the ventricles. And then from there, it's going to branch into the bundle branches and carry that signal towards the apex of the heart, and then out into the Purkinje fibers, which will complete the pathway and get the electrical signal out to all of the heart muscle itself. Now, the Purkinje fibers are going to be a little more elaborate on the left side of the heart because remember, there is much more myocardium on the left side because the left side has to pump with more force out into the systemic circuit. Once the impulse has spread all the way through the Purkinje fibers, the ventricles will contract. Okay, so again, the electrical signal starts at the SA node, spreads through the atria, down into the AV node where it pauses, atria squeeze. The electrical signal moves down the AV bundle, the bundle branches, and out through these Purkinje fibers, which you can see there's more of them over here on the left side, and then the ventricle squeeze. Okay, so there is a little animation. So pay attention to how that contraction is happening. Notice that it's both atria, then both ventricles. So let's walk through a couple of imbalances that are some defects that are in the intrinsic conduction system. One would be arrhythmias. Arrhythmia is just an irregular heart rhythm. And the other term that I have listed up here is fibrillation. Fibrillation is very rapid, very irregular contractions in the heart muscle cells. They are useless for pumping blood. Basically, it's when the muscle cells all contract individually, and it makes it look like the heart is quivering. Circulation ceases, and this can lead to brain death. Typically, in order to treat a condition like fibrillation, this is when they would use those electrical paddles and shock someone back into a normal sinus rhythm. We call that defibrillation. So here is a time-lapsed video of ventricular fibrillation. So you can see the heart has swollen, and you can tell that it basically looks like it's quivering. Nothing's happening. A couple of other imbalances that affect that cardiac electrical impulse is, in order for the impulse to make it from the atria to the ventricles, it has to pass through the AV node. So anytime there's an AV node that is not functioning, we call that a heart block. So a heart block is just a defective or non-functioning AV node. There can be few to no impulses that make it down into the ventricles, because remember, your SA node setting the pace is in the atria, and it's got to be able to make it down to the ventricles. There's no gap junctions there. So if there is a heart block, what happens is, because so few impulses make it to the ventricles will beat at about 30 beats per minute, which is too slow to sustain life. And so this is when someone would have an artificial pacemaker put in. So we don't put in an artificial pacemaker typically if the SA node is not functioning. Instead, it's when the AV node is defective and not able to put the impulses down into the ventricle. And if that's the case, an artificial pacemaker is like some lead wires that get fished down into the ventricle that'll carry an electrical current. And then there's a battery that is implanted on the chest, just under the chest, the skin of the chest, that can be recharged. So the next thing we're going to walk through is electrocardiography. We call this an electrocardiogram. Sometimes it's an ECG or an EKG. This is basically all of the action potentials that are generated in the heart at any given time. And so it looks like this, right? You've ever seen maybe some graphs that show a reading like this. And so all of these waves that you see right here, they're all given names, and they all represent a certain part in the electrical pathway. And so if one of these waves doesn't look right, they know what part in the electrical pathway is not functioning. Okay, so the three waves are the P wave. The P wave means that the SA node is depolarizing. When the SA node depolarizes, it sends that electrical signal through the atria, and the atria will contract. So P wave typically represents not only the SA node depolarizing, but the atria contracting. The QRS wave is really big, so we call it a complex. And this is the ventricles depolarizing. And again, remember, depolarization will lead to a contraction. So this is the ventricles are really contracting. And during that time, the atria are repolarizing. So the atria are relaxing back out. And then the last wave, the T wave, is the ventricular repolarization. So the ventricles are relaxing back out. So the term depolarization is going to lead to a contraction. That term repolarization is resting. Okay, these are some terms we used in muscle physiology and anatomy 1. So let's look here at our EKG, and we can see again, here's our P wave. It is the first wave. It is kind of small, but that is the atria contracting. This bigger wave, QRS, represents the ventricles contracting. And then this wave over here, the T wave, is the ventricles relaxing back out, repolarizing. Okay, so that's a normal EKG. So normal sinus rhythm, we can see up here in the top left, right? So if we look, we can see that we have a P wave, we have this big QRS wave, and here's our T wave. We have a P wave, QRS, T wave. P, QRS, T wave. So that's normal sinus rhythm. Now the one right next to it called junctional rhythm. Okay, let's look at what we have. So notice that there is no P wave here. So we have this big QRS, we have a T wave, and then there's no P wave. QRS, T wave, but no P wave. Okay, so we're missing the P wave. So this would indicate that the SA node, the heart's pacemaker, is not setting, it's not functioning. And so there's no P waves. So typically the heart is being paced now by the AV node at about 40 to 60 beats per minute. Okay, this is enough to sustain life. It's just going to lower circulation. If you look at C down in the bottom left over here, we can see this is called a second degree heart block. So if we look, notice that there's a P wave, there's this QRS, here's T, here's a P wave. Uh-oh, we're missing a QRS. Okay, here's a P, QRS, T wave, P, missing that QRS. So it's almost like every other time the QRS wave is missing. And so this basically means that some of the conductions are not making it down into the ventricles. And so this is why we're missing some of those QRS waves. And so someone with something like this might have to have a pacemaker put in. So this would be, we're not getting the electrical current down into the ventricles. And then D, that is ventricular fibrillation, like the video I showed you. It is a hot mess. The EKG is just incredibly erratic. You cannot identify P, QRS, or T waves in this. This would rely on defibrillation to get back into a sinus rhythm. Now remember, we also have heart sounds. What creates a sound in our heart when we listen with a stethoscope is the closing of our heart valves. So when your AV valves and semilunar valves shut, we hear that, just like shutting a door. So your heart sounds like this: lub dub, lub dub, lub dub, lub dub, lub dub. The lub, the first sound, are the AV valves closing. The second sound is a little louder, the dub, and this is the semilunar valves closing. Remember, those go from ventricles out to large arteries. Now, those semilunar valves, remember, there's a lot of pressure behind those ventricles squeezing that blood, especially out through the aortic semilunar valve. There's so much pressure that if you were to cut the aorta and let that left ventricle squeeze, blood would spurt 6 feet in the air. So there's a lot of pressure behind and force behind that blood. And this is why the closing of those semilunar valves creates a louder sound. So this is why you hear a lub dub, lub dub, lub dub. The second sound is louder because there's more pressure behind the blood leaving those semilunar valves as they shut. Now there is sort of a pause between the two, and that's just relaxation, because remember, atria squeeze, then ventricle contract, atria, then ventricles. Now, there are something called heart murmurs, and heart murmurs are when you listen with a stethoscope, it does not sound like lub dub. Instead, it sounds maybe like a sloshing sound or almost like a slurping sound, and that indicates blood is actually moving backwards through a valve when it should not. So you can actually hear that. So one of the things that we can do with our stethoscope is, if you've ever noticed when you go to the doctor, they don't just listen to your heart, they actually move the stethoscope around in different locations. And what they can do, depending on the location, is they can identify the 4 valves that are in your heart and specifically listen to those valves. And so, to hear the pulmonary valve, the stethoscope would be placed slightly left of center. To hear the mitral valve, that bicuspid valve, the left AV valve, they're all the same thing. It would be placed left of center, but lower. To hear the tricuspid valve or the right AV valve, it would be right of center. And to hear that aortic semilunar valve, you can see it's right of center, but higher, okay? So in the chapter 18 module, I have a link out to this website, which allows you to hear different heart sounds. So it's interesting to listen to these because it lets you see that it sounds very different. So people that are experts, cardiologists, can listen to that and they can identify exactly what the problem is based on the sound. So this is just kind of an interesting website if you're interested in checking that out. Again, I have that linked under the chapter 18 module.